Quality of life was assessed in the MA.17R population, and that's really important because when we're making these decisions for the global population who has a small expected benefit in terms of risk of distant recurrence, we always need to think about risk versus benefit. Interestingly, the quality of life instrument in MA.17R did not show a deterioration of quality of life in the treatment arm versus the placebo arm, so the patients receiving continued therapy with letrozole. But how does that really fit into what we see in our clinical population? What they saw were more menopausal-like symptoms, the exact same symptoms we're used to seeing with aromatase inhibitors, more joint symptoms, but it didn't cause deterioration. What could that reason be? Well, it turns out that women who tolerate aromatase inhibitors tolerate aromatase inhibitors. So they're not going to have more side effects than they already had. And of course, we started with the baseline quality of life that they had while taking an aromatase inhibitor when they were randomized to placebo or not. So it's quite intriguing. Again, the self-selection may play a very big role, that the selection of patients who tolerate therapy is really important because those patients will continue to tolerate therapy and they won't have ongoing symptoms which affect quality of life.
So the MA.17R study did not only collected toxicity evaluations, but they also did do a quality of life analysis. And overall, all the quality of life analysis, there wasn't really a huge difference between the two arms. You know, certainly there was some mild drop in quality of life in the patients who got the letrozole versus not, but it really wasn't of much significance. However, they did notice an increased fracture rate with letrozole, an increased rate of new onset osteoporosis, despite about 50% of patients were taking bisphosphonates, so that's obviously a quality of life issue for patients. We don't want them getting fractures. I think we have to remember from the MA.17R study is that this is a highly selected group of patients because they'd already had 5 years of an aromatase inhibitor and done fine with it. So, you know, I think most times if we see joint pain, it occurs fairly early on in patients taking these drugs. So it would be pretty unlikely that after 5 years a patient would suddenly get joint pain. So I think they are very selected, and I think certainly in our practices we see a lot of patients that just can't do the 5 years, or certainly they don't want to do more than 5 years of treatment because, you know, the joint pain, the menopausal symptoms are affecting their quality of life. So I think with the caveat that this was a selected group of patients, there didn't appear to be a huge difference in quality of life between the two arms.
There's always a risk for overtreatment in anything we do, treating women with early stage breast cancer, whether it's chemotherapy or hormone therapy. We now have to be, with this emerging data, more concerned about overtreatment with hormone therapy. I think in the past it was all about undertreatment, you know. Now we don't want to be treating everybody with 10 years of hormone therapy. Women who have a low risk of recurrence when they start still have a low risk at 5 years of their ongoing risk of in terms of their ongoing risk of recurrence. So I wouldn't treat those women with extended adjuvant therapy. Once we get to node-positive tumors, larger T size, those are women who I consider for extending adjuvant hormone therapy, particularly those women who are tolerating therapy well.
So as far as extending aromatase inhibitors to 10 years, I think we don't really at this time point have a really good way of saying which patients need that approach versus not. I think overall, if I have a patient who is at high risk of recurrence based on stage and nodal status, I do tend to keep those patients on aromatase inhibitors really to at least 10 years. In some patients, we'll even continue longer than that. So I think what we really need is some molecular profile to tell us the biology of the cancer and kind of indicate what the risk of having a recurrence beyond 5 years or beyond 10 years is, so that we can kind of pick or select patients, you know, in a more definitive way who are really going to benefit from this treatment. So I think we do it on an individual patient basis. I think it depends on what you think their risk is, risk of recurrences beyond 5 years, but also how they're tolerating the drug is very important.
So we're waiting with bated breath for the results of the NSABP B-42 trial. It's a cleaner study than MA.17R, and likely will, in general, probably have randomized more women at higher risk. I don't know the demographics of that trial yet, and I'm really waiting with a lot of interest in those results, because I think that they're going to help us a lot in understanding the benefit of extending AI therapy after 5 years in a more homogeneous population, and understanding the risks, as well as which patients are more likely to benefit.